All right, Learning Plan 1 is all about achieving quality care and evidence-based practice. This is a critical concept to understand. It's a challenging concept to understand. We're going to tackle this one right off the bat and dig into this. And I'll let you know right up front, excuse me, each learning plan I will record the lectures, but I will be breaking them into a number of small lectures. In this case, there will be 7 segments to the lecture. I'm hoping each are going to be in the range of 10 to 20 minutes each. I'm not exactly sure, but there'll be short little lectures that'll be easy to watch on YouTube. You can watch them on your phone, your iPad, your computer, whatever you want. So I just want to give you know that I'm not going to record 3-hour lectures. They're going to be all little mini lectures. So let's start off with achieving evidence-based quality care. And what do we mean by quality care? We look at outcomes, and we use evidence to apply the best practices. Just because many nurses do what they've done because they've always done what they've done. And as students, we want to bring in the latest research, the best practices into practice. And we're going to look at continuous quality improvement, and there's a number of different terminologies for that. We'll get to that in a couple of segments. We're going to talk about the change system, which is a freeze, move, and refreeze idea. And we're going to talk about sentinel events and near misses and why a mistake is so important. I mean, we don't want mistakes, but we will make mistakes. That's the nature of being human. So we want to make sure we use the mistakes in the best possible way. So the Institute of Medicine has done research and says that part of the problem is healthcare is very fragmented and is poorly organized. And a lot of that is to do with there's clinics, and there's urgent care, and there's hospitals, and there's home care, and there's public health, and not necessarily do all systems talk. Now, some things are improving. If you get within like the Aurora system, almost everybody in Aurora uses Epic and as electronic health records, and so they do talk to each other better. But it's still very fragmented because people can go anywhere they want, and you can go to multiple doctors in different systems, and they don't necessarily talk to each other very well. There's been an increase of chronic illnesses, which has a major impact on the system. What do we mean by chronic illness? Something that has been lingering for more than 6 months. Diabetes, major one. Heart disease, cancers. Something as simple as arthritis, which if you had it, isn't simple, which is what resulted in my knee replacements. I had chronic osteoarthritis of the knees. They were bone on both legs, which results in I get metal knees. So that's part of the problem with the quality of care. And the system is very complex and confusing. Have you looked at one of your statement of benefits or EOBs? I forgot what it's called, but it's when you get it from your insurance company, they say they're going to pay this but not this because this and that. It's confusing. It really is confusing, and we're professionals. You will be professionals. Nurses are trained to do this stuff, and we look at these documents and we're like, I don't know. So there's been a safety crisis. Since 1999, the IOM realized that 44 to 100,000 people die annually because of error. And medical errors were the 8th leading cause of death. Can you imagine? That's bad. That's a problem because people don't talk to one another. There's miscommunication, and people neglect to make quality improvement. So we look at continuous quality improvement. And this goes by many names. Quality improvement, QA. TQM is total quality management. You could call it risk management, which is what most hospitals call it, or it could be Six Sigma, and that comes right out of Toyota and the automotive industry. So but all of these have the same thing in mind: improved outcome, better outcomes. And so each one of these looks at what works, what doesn't work, why doesn't it work, what can be done to make it work better, what works, what can we do to make that even better. It's always trying to improve the outcomes. It's not necessarily looking for cost savings, although a lot of times better outcomes do result in cost savings. If you have better outcomes and your patient is discharged 1 day earlier, that's cost savings. If you have better outcomes and there's fewer rates of infection, that's cost savings. But that's not why they're doing it. They're looking for outcomes, patient outcomes. So what's the nurse's role in all this? I mean, as a nurse, I take orders from the doctors, right? Doctors tell me what to do. That pretty much informs what I can do, correct? Only 8% of doctors consider us to be decision makers, yet they think most errors were nursing errors. So where's our role in that? Our role is to stand up and make sure that we are that final stop. A doctor can write an order, and you can follow that order. If it's a wrong order, are you responsible? We'll talk about that in the legal lection in Learning Plan 3, but yes, you are responsible. If you follow a wrong order and you knew it was wrong, you're responsible. So we need to develop our voices so that when we see something that we think is wrong, we have to sound out. We have to be willing to say, I think this is wrong, or I think that could be better. And if we have evidence to back it up, that's much, much better for us. So nurses don't usually design the QA systems of hospitals, but we need to understand how they work. What are the benchmarks? What's the hospital shooting for? We need to evaluate causes of poor outcomes. If we see patients that are getting chronic UTIs after a surgery, we need to look at what's going on. Is there a structure problem? Is there a physical object that's causing problems? Or is there a process that's going wrong? Are we not removing the catheters early enough? So that's what a nurse can do. A nurse, because we spend so much time with those patients, we can be the first line of defense. So I talked about structures and processes. What do I mean by structure, process, and outcome? Well, to boil it down to really simple, structure are things. You can hold things. Like I used the example of a catheter. Catheter is a structure. And let's use this exact scenario. You work in a hospital with a high rate of UTIs, catheter-associated UTIs. So the structure is the catheter, right? The process is how long do you keep the catheter in, or it's what we do. So part of the process would be cath care, peri-care, early removal, pushing fluids. That's process. Structure you can grab onto, and I'm grabbing onto a catheter. Process is what we do, how we take care of it. The outcome is the end result. So the assumption is structure and process creates the outcome. So to change the outcome, we have to change either the structure or the thing or the process, the action. It's really important that you understand the difference between structure, which is a thing, process, which is an action, and outcome is the end result. Now we have some key outcome indicators, and if you look on your PowerPoints that are in your Learning Plan 1, on page 9 of the PowerPoint, you'll see a Medicare.gov nursing home compare page, and this is an interesting site to go to. I encourage you to go out there and plug in the names of a couple nursing homes that you are familiar with and look to see how they compare to one another. It can be kind of shocking. They look at nosocomial infections, patient injuries, satisfaction, skin integrity. Skin integrity is huge. They look at fall rate. They look at hospital readmissions, all those things. Those are key outcome indicators. Those are indicators of successful care. Now in a hospital, we look at hospital indicators. And JCAHO, or Joint, mandates key indicators. We need to monitor advanced directives. That's why whenever you go in the hospital, you're always asked, do you have an advanced directive? Autopsy rates, AMA and elopement rates, blood product utilization rates, and the list goes on. Those are all monitors that have to be done. Now, if we're looking at restraint use, where's the structure? The structure would be the restraint. What would be the process? Well, the process could be possibly how often are they taken off and repositioned, skin care, trying other means of helping the patient maintain control, but those are the processes. There's also a hospital outcome comparison, the same type of Medicare.gov hospital compare. And again, I encourage you to go there and plug in a couple hospitals, maybe the ones that you've done clinicals at or the ones that you go to, and take a look at how they compare to one another. Again, it's always going to be eye-opening because you're going to find something that will just surprise you. Joint has always patient safety goals. They are updated annually. And again, on page 12 of your PowerPoint presentation, there's a link that takes you out to the patient safety goals, the current patient safety goals. And I encourage you to go out there and hint, you need to be able to list 3 or 4 of these at some point in this class, okay? How's that? That's the end of part 1. Come back for part 2. We're going to be talking more about evidence-based practice.